if a patient has chemotherapy after surgery, we would refer to the chemotherapy as adjuvant. So obviously I just realized that I have the answers up, so I can't really ask you, but sorry, it's still early. So is that true or false? Well, we know that this is true, right? If we did chemotherapy before surgery, then we would call it neoadjuvant. And the idea behind that is that surgery is kind of the, and this word is going to sound strange for me to use, but it's sort of the terminal or major treatment intervention, okay? And so for the next question, or actually I should ask, is everybody okay with that? Do they understand? Rad. Okay. Right here. So question 2, your patient is receiving 5 days of concurrent chemotherapy and carboplatin, which is a very common combination because we know that based on the lecture I provided you, that carboplatin is a radiosensitizer, so they work synergistically. So on day 15, the patient develops a significant looking irritation at the radiation site. What do you think is occurring? Well, disease progression is unlikely, and disease progression wouldn't really look like that, right? So when I say disease progression, I mean the patient is, if they have breast cancer, for example, maybe the tumor is getting bigger, or if they have, leukemia, maybe their blood counts are getting worse. And then hypersensitivity, not really. That's not a true hypersensitivity reaction. And usually what we're talking about when we say irritation is it almost looks like a sunburn, because essentially you're getting zapped with a really, really, really strong tanning bed. It's just with gamma radiation as opposed to UV radiation. And then there's radiation recall. Well, we know that radiation recall generally doesn't happen until later. So the most likely or plausible situation is that the patient is just experiencing a synergistic effect of the radiation plus the chemotherapy. Is everybody good with that? All right, cool. Okay, blank is a possible long-term consequence of radiation therapy. Well, sickle cell anemia we know is a genetic acquired or inherited disorder. Acute myeloid leukemia, I'll get back to that in a second. Ovarian cancer, no. I mean, there are risk factors associated with developing ovarian cancer. We know that use of talcum powder, for example, does increase the risk of ovarian cancer. Having a BRCA mutation does. There may be some other additional risk factors like age and having fibroid tumors, which might also increase risk, but radiation therapy is not associated with an increased risk of developing ovarian cancer. Urticaria, nah. It's a short-term consequence, right? So that just means hives or itching. That could happen at the radiation site if the patient is, for example, having a particularly bad radiosensitization. But in terms of the right answer for this, acute myeloid leukemia is correct because, as I mentioned in the lecture, long-term secondary malignancies are unfortunately fairly common for people who are exposed to radiation, especially where the area is a little bit larger. So, for example, we've had patients have large sections of bone marrow irradiated before, and if they have a osteosarcoma in their leg, the long bone of their leg, and maybe some of their marrow is affected, a couple of years later they can develop something called myelodysplastic syndrome, which can turn into acute myeloid leukemia. So acute myeloid leukemia is a more likely consequence, long-term consequence of radiation therapy. Is everyone good with that? Cool.
Real quick, can you go again and say why the ovarian cancer wouldn't be part?
Yeah, so ovarian cancer we really don't have a great understanding of what all the risk factors are for ovarian cancer, but we've not seen an increased correlation between people receiving radiation therapy and then a few years later developing ovarian cancer. So, I mean, it's possible if somebody were, let's say, exposed in a Chernobyl type situation, right? So let's say someone is exposed to a large amount of radiation at one time, not therapeutically through an accidental means, then theoretically it would be possible that any cancer could form because they have DNA damage and they're accumulating mutations from that exposure. But as a therapeutic, at therapeutic doses, we have not seen necessarily that ovarian cancer risk increases with exposure. And we've had a lot of patients who have cervical cancer, for example, who receive, combined chemotherapy and radiation. And it's not typical to, for them to develop that. So I hope that answers your question. Yes?
Yes. Sorry, I muted before I said yes.
No, that's okay. That's right. And someone was sending me a chat message, and I was like getting, I have squirrel brain, right? So it's like shiny. Okay. And like I said, I'll try and answer your questions. I'll probably save the chat questions for the end just because it's so hard for me to go back and forth between screens. All right. So which of the following drugs are both cell cycle phase specific and mitotic inhibitors? Select all that apply. So we know that Taxotere, which is docetaxel, and vinblastine, which is a vinca, those are both cell cycle phase specific, and they happen to block microtubules or mitosis in some fashion. Xeloda is 5-FU, and aloxatin is oxaliplatin. So, were there any questions about that one? That's just, unfortunately, straight up memorization. All right. This is, there we go. Okay. Choose the best statement that describes treatment modalities in cancer care. So combining radiation and chemotherapy increases efficacy but does not increase toxicity. We know that that is fundamentally not true, right? That's why we have things like radiation recall and other, toxicities that happen, radiosensitization, when we combine modalities. A regimen consists of at least 2 therapies and usually includes chemotherapy. Nope, not necessarily. A regimen is just the recurrent treatment that we're going to pick for someone. So, a woman who's receiving endocrine therapy for like tamoxifen for breast cancer, that's a regimen, and that's only one drug. So it doesn't have to be chemo, it doesn't have to be radiation, it just has to be a particular therapy that is being continued for any length of time for a patient. And then targeted therapies have fewer side effects and are more effective than chemotherapy. Well, we know that that is not true. Targeted therapies, the random and strange side effects are often called off-target effects. And so that's just, even if you have a kinase that is directed against, like, for example, Bruton tyrosine kinase inhibitors, it can also affect other parts of the cascade, of that communication cascade, and can cause all kinds of, serious adverse events. So for a lot of the targeted therapies, they can cause rashes, they can cause really serious things like pericarditis, pericardial effusions, hand and foot syndrome, diarrheas. I mean, the list kind of goes on and on. And there are a number of times that I have to actually discontinue patients from using targeted therapy because they can't tolerate it. And I've had patients say that they were able to tolerate their chemotherapy better than their targeted therapy. So it really just depends on what the disease is, what the drug is. But I definitely don't want you to get the sense that targeted therapies are less scary in some ways for side effects than chemotherapy. And there's certainly, it's not necessarily more effective. Chemotherapy usually is very effective for patients, especially if they're incredibly sick. So often what will happen is when a patient gets diagnosed, they might be really ill from the disease. And one of our first inclinations to make someone feel better and to have it work fast is to give them chemotherapy. Because targeted therapies can take weeks or longer to actually start showing an effect. So it's typical for us to try and use the chemotherapy route, get a patient stabilized and more comfortable, and then switch them to another modality. And so when agents or modalities are combined, additive toxicity can occur. That is true. And I have mentioned that before. All right, I see a question.
I have a question, Dr.
Yeah. Sure, go ahead.
Hello?
Yes, I can hear you. Go ahead.
I lost somebody.
That's okay. I can hear you. Okay, that's all right. I'll get back to the question. All right. So your 28-year-old female patient, TT, is diagnosed with early stage breast cancer in her right breast. So when you hear early stage, do you think of stage 4? No, right? So typically for stage 4, we know that means that patients have metastatic disease, so that means they have disease somewhere else other than the original tumor. So if it's early stage, we're probably talking stages 1 or 2, okay? 3 becomes more advanced, and then 4 obviously is generally metastatic, although, again, it depends a little bit on the kind of cancer. So the surgeon recommends proceeding with several cycles of chemotherapy prior to removing the tumor and breast tissue known as a mastectomy. The following is true about your patient's chemotherapy. She's receiving palliative adjuvant chemotherapy. Nope. Because we're not doing any palliation for this patient, right? We're curing her because she's got an early stage breast cancer. So she's not receiving any kind of palliative care. She's receiving curative neoadjuvant chemotherapy. That's correct because we're giving her chemotherapy prior to doing the surgery. If we did the surgery first and then gave her the chemo, it would be adjuvant chemotherapy. And that kind of is the reverse of the question that I asked in number 1. Does that make sense to everyone so far? Awesome. All right. And then I figured out that I could add pictures, which is super rad. I was very excited about this because pictures are really great at telling stories.
Real quick.
Yeah.
Sorry. On the last one, you're talking about curative chemotherapy. So the actual definition, and just as I was going through this question, I see it as more aggressive therapy with the goal of curing the patient. Is kind of how I have it defined. Is that necessarily more aggressive, or is that just kind of like generalized treatment that is meant to cure? I guess I want to get the right definition out of it.
Yeah, that's a good question. And that one, so that question is up for a little bit of debate and controversy within the oncology community, in part because as cancer becomes a more chronic condition for many patients, we are starting to use, and we have been using, far more aggressive therapies that had typically been reserved for people who were absolutely curative. So, it's the waters are becoming muddied a little bit when it comes to definitions, but for our purposes, I just want you to know that generally speaking, if we're doing curative intent, we're going to be generally more aggressive because the assumption is the patient is, has a good performance status. So that means that they're able to tolerate the treatment that you're recommending, that there is a high likelihood that they will recover from the cancer and be cured of the cancer. And for our purposes, the definition of cure is usually no recurrence within 5 years. And then at the point that you've reached 5 years, you're considered cured. It's kind of arbitrary, but it's based on the American Cancer Society data collection cycles, and the survival rates are essentially cut into parcels of like 5 years. So that's how the data is measured. But it's hard because there are patients who don't have curative diseases for whom we give very aggressive chemotherapy to try and put them into a remission for as long as we can. But I'm not going to go into nuanced details like that with you guys because it's confusing even for clinicians at this point. Does that help?
Yes.
Okay, great. It's so weird answering questions on Zoom. Sorry, I'm still getting used to this. I'm sure you guys are too. All right. WV is your 52-year-old patient who received whole breast radiation 8 months ago for locally invasive breast cancer. Unfortunately, she's had a recurrence, and her oncologist has decided to begin chemotherapy immediately. Within several days after her first cycle of doxorubicin and cyclophosphamide, she presents to the clinic with burning and painful skin around her previously irradiated breast. So you've got a pretty substantial picture here of what looks like, had been the radiation field. So one of the things that we do when we aim radiation beams at patients, and there are all different kinds of beams. There's, stereotactic, which usually means it's kind of a little bit more specific to an area. We try and do organ blocking and, use mathematical models and equations to help prevent the scatter of radiation to adjacent organs, because that can be very damaging. But you can see, this is a sort of a normal sized field for breast cancer treatment. And she's got, really angry, kind of inflamed area around where she'd been treated. So based on the time frame too, so 8 months ago she had therapy. She got whole breast radiation. Sometimes we'll do just, again, the small beams, but in this case it was everywhere. And the guidelines at this point and many other breast oncologists really do recommend whole breast radiation as opposed to just doing a small spot. Because we know that the outcomes for patients in terms of recurrence are usually better. So we also know that doxorubicin is a radiosensitizing agent and can cause radiation recall. And since it's been so many months since she had therapy, the fact that it kind of reinvigorated the area that she had irradiated means that we know that this is radiation recall. And I've seen this. Now, this picture is not obviously a picture of one of my patients, but I've seen this happen many, many times. And one of the problems is, this can actually happen even years after patients have radiation. So we've seen it up to 2 or 3 years after patients have had radiation. And the problem is if you don't make the connection, your patient's freaked out, you're freaked out, you're like, are you having a reaction to the medication I've given you? Do I need to switch? So part of what's important in this context is kind of tracing back, okay, where was the radiation field, if you can get records, and then figure out if this is indeed related to radiation recall. Does that make sense? Cool. All right, so one of the 3 ways that alkylating agents kill cancer cells is through, well, it's not inhibition of topoisomerase 1. It does not, they don't stabilize the mitotic spindle because alkylating agents are not cell cycle phase specific, right? Nucleotide mismatch leading to mutations, yes, that is one of the ways that they do it. They also attach alkyl groups and they can cause strand breakage and things like that. And then incorporation of similar nucleotides into RNA, no, they're not pyrimidines or purines or anything like that. Does that make sense? Cool. So dosing of chemotherapy agents varies by agent. So for carboplatin, we generally dose using AUC, right? So very rarely will you see milligrams per meter squared used for carboplatin. And if you do ever see that, you should question the order. So the caveat is sometimes we'll use it, again, rarely, but we'll use it more in pediatric cancers, just because the creatinine clearance is usually much overestimated because they're little, or we don't have a really good sense of how fast their kidneys are clearing things. But generally speaking, we use area under the curve, and we calculate the final dose by the Calvert formula, which we'll get a little practice with in a few minutes. All right, any questions with that? All right, last one. So, which agent is considered a humanized monoclonal antibody? So the humanized ones have the Zumab, right? So trastuzumab. One of the nice things about the humanized monoclonal antibodies is that they typically have fewer reactions, infusion-related reactions, than obviously something that's chimeric, so it's mixed with murine DNA, or it's or antibodies, or you have a kind of a combination, part human, part mouse, things like that. So as much as we can have fully humanized or fully human or humanized monoclonal antibodies, that tends to be kind of the best case scenario for patients. Does that make sense? Cool. All right.
Can you hear me, Dr. Leva?
I can hear you now, yes.
Okay, I have a quick question for irat question number 5.
Sure. Yes.
So I agree with the answer choice here that when agents are and modalities are combined, digestive toxicity can occur. What I know from past is probably this is my misconception in my head about this is usually we combine agents so that we reduce the dose-related toxicity. And we try to avoid the two combination of drug where they have the same toxicity. So previously, before I answered this question, in my head, my concept was wrong. Probably I read it somewhere, or I just want to know the more clarification that we do combination of therapy to avoid dose-related toxicity, and over here is the opposite of it. So I just want to
Yeah, no, that's a good question. So you're right that oncology is kind of the opposite of all other therapeutic areas. So we want to, and this is going to sound bad, but it's going to make sense in a second. We actually want to combine as much toxicity as possible to kill off all the bad cells. And unfortunately, that means that, patients normally end up having lots of toxicities. So the other thing to think about is we often want to combine cell cycle phase specific and non-specific treatment modalities so that you can kill cells at different stages of development and when they're in transit to another growth cycle, right? And in order to do that, when you have drugs that have very narrow therapeutic indices, which pretty much all of these drugs have a very narrow therapeutic index, which if you remember from PDA just means the dose to treat you is kind of close to the dose that can kill you. So we're essentially dispensing little bits of harm and every time we give people chemotherapy. Whether we give you one agent or multiple depends on the kind of cancer you have. It depends on your baseline health status. But we really don't have the same kind of dose escalation that you're talking about with like heart failure, for example, or, if someone has hypertension, we like to use little bits of a few drugs to help work in different ways so that we don't make someone feel hypotensive, right? That's unfortunately not at all related in oncology. Where this is a little different is when we talk about supportive care, when we move on to the discussion about anti-emesis, vomiting, nausea, stuff like that, then we try and use those principles, right? So we want to try and hit different drug targets to help prevent nausea or to treat nausea and vomiting. And we want to try and use the lowest possible dose we can so that we don't have a lot of bad side effects. But that's only because we're trying to help make the patient feel better, not because we're trying to kill the cancer. Does that make sense?
it makes sense now, because if I have not listened to you on the presentation and I just read something, I would pick C, and that would be totally wrong answer.
Yeah, so right. And we know that targeted therapies do not have fewer side effects. They just have different side effects, right?
Yes.
And this is it's an important thing that you brought up, because a lot of patients make the assumption that, oh, you're switching from chemotherapy to, a targeted agent. And the problem is that a lot of these targeted agents are all over the TV, right? Because there's direct consumer advertising. So if you're, watching the Super Bowl or whatever, you're seeing that all these famous golfers and, whatever people are getting these drugs, and they are able to do all the same things, and they're feeling really healthy. And so patients get a false sense of security, like, oh yeah, this is great. I'm not going to have any problems. So one of your jobs as a pharmacist is to make sure patients take it seriously, because they can, I've had patients have grade 5 events from targeted therapy. So that means I've had patients pass away because of targeted therapy. So it's important to know. Awesome. Cool.
Thank you.
Yeah, of course. All right. Sure.
Question, but if given a patient case, how do you differentiate between the radio sensitization and hypersensitivity? Because they kind of look similar.
Yeah. So hypersensitivity, generally speaking, is more hive-like. They actually look very different in person. So when it comes to this, I'm just trying to I want you to understand the concept of some of the different things that can happen to patients when they're exposed to a combination of radiation and chemotherapy. But I'm not going to necessarily expect that you're able to tease out all the nuances, okay? So generally speaking, my irat questions are usually a little bit harder and more specific to help generate discussion than the exam questions, because you have limited time with the exam and those are high stakes. So I try and focus on things that are more kind of like just, a quick patient case about, what other side effects a patient might have from radiation therapy, things like that. But the other thing that's important is with a hypersensitivity reaction in real life, when I'm looking at someone who's, let's say, on carboplatin plus radiation, they typically will have hypersensitivity reactions that are more, throat related, like when they're getting the infusion of the chemotherapy, because you don't get hypersensitivity from radiation. So radiation itself doesn't cause hypersensitivity. You might have hypersensitivity happen because you've added chemotherapy, and the radiation accelerates the way the chemotherapy works. Okay. It may put you in a position of having essentially a higher exposure to the chemotherapy, which can cause a hypersensitivity reaction. Does that make sense?
Yeah, thank you.
Yeah, and the other thing to note too is that hypersensitivity reactions typically occur within 48 hours of receiving an agent, okay? So even like getting stung by a bee, and we separate out hypersensitivity reactions into 2 categories. One is IgE mediated, which is the more you're exposed to something, like penicillin, for example, or bee sting, the more sensitivity you develop. And then there's what's called a non-IgE mediated reaction, which is more like what people with celiac, like myself, have when we're exposed to a protein that we're develop an allergy to. And we'll talk actually a lot about hypersensitivity reactions when we talk about the platins and the taxanes, and I'm going to actually talk about that today. So that was a well-timed question. Thank you.
Okay, thank you.
Cool. All right. So were there any other questions before we move on? No. Okay, great. All right. So let's see here. I have to. Here we go. Okay. Oops. I have more questions. Oh, cool. Dr. Ofsted is here. Yes. Go ahead, Dr. Ofsted.
Just let me know if you want to test the breakouts.
Oh, yeah. Sure. So we did test them earlier, and they seem to work, although unfortunately not everyone is assigned to the rooms, it looks like. So I made some manual assignments.
But most people are in the right room.
I believe so, yeah. Although when I try, we can actually try right now, if that's okay with everyone.
Sure.